Hi, I'm Dr. Dan Lee. I'm a gastroenterologist at Kaiser Permanente, Northern California. I want to thank Gastrointestinal Endoscopy for inviting me to present our study entitled Diagnosis and Predictors of Sessile Serrated Adenoma in a large, community-based, integrated healthcare setting, which will be published in GIE. First, let me briefly talk about the background of this study. Colon cancer is the second leading cause of cancer-related death in the United States. About 20 to 30% colon cancers develop from serrated polyps, and in particular from sessile serrated adenomas, or SSAs for short. SSAs are typically located in the proximal colon and can be difficult to identify by gastroenterologists at the time of colonoscopy because of their flat morphology and subtle endoscopic appearance. Without training, SSAs can be easily missed at the time of colonoscopy. In addition, pathology expertise is also very important in making the correct diagnosis because SSAs can be misdiagnosed as hyperplastic polyps, which are considered to have lower risk of colon cancer. So far, the knowledge regarding the diagnosis and prevalence of SSAs in community practice is still very limited. Therefore, we designed and conducted this study at Kaiser Permanente, Northern California, which is a large, community-based, integrated healthcare system. Our study has three parts. In the first part of the study, we investigated whether educational training can improve the diagnosis of SSAs among gastroenterologists and pathologists in community practice. In 2012, we invited Dr. Sanjay Kakar, who is an academic GI pathologist at the University of California in San Francisco, who has extensive expertise in diagnosing SSAs. We arranged a joint GI pathology conference at three large Kaiser Permanente medical centers. At each medical center, Dr. Kakar gave a 1-hour didactic lecture on the pathology features of SSA and its diagnosis. The lecture was well attended by gastroenterologists and pathologists at each medical center. After the training, we measured the SSA detection rate, or SDR for short, at the three medical centers. And we noticed a significant increase of SDR from an average of 0.6% before training to 3.7% after the training. In addition, there was an increase in the detection of proximal SSAs, accompanied by a decrease in the detection of proximal hyperplastic polyps. This finding suggests that more serrated polyps were classified as SSAs instead of hyperplastic polyps after the training by pathologists. Taken together, our findings suggest that educational training was very successful in improving diagnosis of SSAs among gastroenterologists and pathologists in community practice. In the second part of the study, we investigated the patient-level predictors of SSA detection. In multivariable regression analysis, we found race ethnicity was an independent predictor of SSA detection. For example, Asians were 54% less likely, and Hispanics 41% less likely to have SSAs compared to non-Hispanic whites. The presence of conventional adenomas or hyperplastic polyps and current smoking were associated with increased risk of SSAs. In this study, we found age or gender was not an independent predictor of SSA detection. In the last part of the study, we investigated the SSA detection rate, or SDR for short, among experienced gastroenterologists. We found a wide variation of SDR among experienced gastroenterologists, ranging from 1.1% to 8.1%. Our findings suggest more training will be beneficial to further improve the diagnosis of SSA among gastroenterologists. In addition, we found a moderately strong correlation between SDR and the detection rate of conventional adenoma, or ADR for short. The correlation coefficient between SDR and ADR was 0.64. So what does it mean? First, the strong correlation between ADR and SDR indicates that ATR can be used as a reasonable surrogate for SDR for the measurement of detection of SSAs. That being said, the moderate strength in correlation also indicates possible discrepancy between our skills of detecting conventional adenomas and SSAs. For example, an endoscopist with high ADR may have low SDR. Recently, there was a paper published in GIE by Dr. Anderson and his team, which proposed the notion of establishing a separate quality benchmark for detection of clinically significant serrated polyps. Further study will be beneficial to assess whether such approach will be necessary and feasible. In summary, our study represents a comprehensive evaluation of SSA diagnosis and predictors in community practice. Educational training was very successful in improving the diagnosis of SSAs among gastroenterologists and pathologists in community practice. We found race, ethnicity, presence of coexisting conventional adenomas or hyperplatic polyps, and current smoking were independent predictors of SSA detection. There was a moderately strong correlation between SDR and ADR. Our findings suggest that an ADR can be used as a reasonable surrogate marker for SDR, although there could be discrepancy existing between the endoscopy skills of detecting conventional adenomas and SSAs. In the future, we plan to investigate the longitudinal risk of colon cancer and advanced neoplasia in patients with SSAs. Finally, I want to thank Kaiser Permanente Northern California Division of Research for their assistance and funding of this study. I appreciate your interest. If you have any questions related to this study, please feel free to let me know. Thank you.